Good afternoon, everyone, and welcome to the webinar. Today's topic in our Stay in Care series is treatment options for valve disease, and this is a stay in care with CHD. Before we begin, I would like to just give you a couple of notes that will make your experience a little better. All attendees are in listen only mode. If you cannot hear, hopefully you can read the slides. Check the audio button on your personal computer to assure the sound is on. Please type your questions into the Q&A box at any time during the presentation, and questions will be read and answered after the presentation is over. We love questions, but please note that Dr. Martin will not be able to answer questions about your child specifically or about you as a patient, as she's not your treating physician. The PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Little Hearts website following the event. As you know, or maybe not, the Mended Hearts Inc. mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. The Mended Little Hearts program serves the littlest heart patients of all, those who have congenital heart defects and their families. I am Andrea Baer, the Executive Director here at Mended Hearts, and with me I have Jody Smith, who is the National Program Director for Mended Hearts. And we would just like to give acknowledgement to Medtronic for the educational grant that is making this webinar and others possible. And now I'd like to introduce to you our guest speaker today, Dr. Mary Hunt Martin, who is the director of the Adult Congenital Catheterization Program and Associate Professor of Pediatrics at the University of Utah. Dr. Mary Hunt Martin is a board-certified pediatric cardiologist with over a decade of experience in clinical and interventional cardiology. She is an associate professor of pediatrics at the University of Utah with an adjunct professorship in internal medicine and is the director of adult congenital catheterization program at the University of Utah. She specializes in cardiac catheterization and interventions in children and adults with congenital heart disease. Dr. Mary Hunt Martin, I would like to just welcome you, and I will turn this over and stop sharing, and you can take the controls away. Thank you.
Okay, thank you so much, Andrea. Let me check on my screen sharing abilities. Here we go. Yes, and screen 2. All right, did I share the right screen?
You did.
Excellent. Okay, thank you so much for inviting me to give this talk. It's really an honor, and this is such an important topic, especially in these times where it's kind of frightening to go anywhere. And it's really important that, especially if you have heart disease, that you stay in care. And so I'm really commend Mended Hearts and Mended Little Hearts for putting this webinar on. As Andrea said, I work at the University of Utah at Primary Children's Hospital mostly, and I have no disclosures. And so to spice up my disclosure slide, I decided to compare myself to Dr. Justino, who gave the first talk in this series. I'm also going to be using his talk quite a bit to go through, to review how he reviewed valve disease, because it was very helpful. So I have no disclosures. Dr. Justino has lots of disclosures. He started a company. I haven't started any companies, and he grew an awesome beard during COVID, and I did not grow an awesome beard during COVID. But we are similar in some ways. We both love our work in the cath lab. We both really care about our patients a lot, and we both dedicated our lives to taking care of people with congenital heart disease. And we both love long walks on the beach, although actually I don't know Dr. Justino well enough to know if that's true. And in truth, I prefer short walks with a nap on the beach afterwards. So let me give an overview. Because I'm a cardiac interventionalist, which means I work in the cath lab, and this talk is going to be mostly about transcatheter valves, we'll talk about some things in overview, but we're going to spend a lot of time focusing on this valve here, circled in red, the pulmonary valve, because It's a really important one. They're all actually quite important. But it's one that's often affected in kids with congenital heart disease. But to start out, let me tell you what we're going to talk about in overview. So first of all, I'm going to review how valves work using a lot of Dr. Justino's images and drawings, which I think were beautiful. Why it's important to get treatment when you need it, how you know when you need to seek treatment, how valve disease can be treated, current non-invasive approaches. Non-invasive, we typically are talking about cath lab valves that can be fixed or new valves that can be delivered with catheters rather than open heart surgery. I'm going to talk about new innovations in the field. And then we'll talk about, as a patient, what your post-treatment care will be like after you've had treatment for valve disease. And finally, to bring it back to the topic of the webinar, we'll talk about the importance of staying in care. So after Dr. Justino's talk, Jody said that was the most clear and perfect explanation of valve disease I have ever heard. So rather than trying to do better than the most clear and perfect ever, I'll just review Dr. Justino's explanation of valve disease, which was quite good. So when he started off with a garden hose and a bulb syringe, I really wondered where he was going. But if you saw his talk, you know that he used an example of cutting off the ends of a bulb syringe and attaching a garden hose on either side. In this example, when you don't have any valves in place, if you squeeze that bulb, the water or the fluid goes outward in both directions, like in this picture here. The water will squirt to the right and left. And then when the bulb is released and is able to re-expand, it will suck fluid from both directions back into the bulb. So you could squeeze that bulb all day long and nothing productive would happen. Fluid would just slosh back and forth. However, if you put a valve, two valves on either side, a valve on either side of the bulb syringe, an inflow valve and an outflow valve, as in this first picture, when you squeezed the bulb, the inflow valve would stay closed. This is a one-way valve, and so it prevents leakage of the fluid in this direction. And so fluid would just squirt out one end of the bulb. And then when you release the bulb and the bulb is able to re-expand, fluid would rush into the inflow end, but the valve on the outflow side would close so that no fluid from that side could rush back into the pump. So if you squeezed this bulb all day with the valve on either end, you would get flow in one direction. And this is how our heart works. Our heart really is composed of two pumps, or in some cases with our kids with congenital heart disease, one pump that pumps the blood around the body. And the valves are so critical because if the valves did not exist, we would not exist, quite honestly, because we need our pump to be able to push blood up to our brain and bring it back from our body. And if we don't have valves, it's unable to do that. So there are a lot of different types of valves in the world, and most valves wear out over time. If the valves in your car get bent, then you need a car mechanic. If the valves in your plumbing get leaky, then you need a plumber. If the valves in your heart are having an issue, then you need either a cardiac surgeon or a cardiac cath doctor. And I'm going to use in this talk the words cath doctor and interventionalist interchangeably. Those basically mean the same thing in our world. So, like we talked about in the other types of valves and in the picture that Dr. Justino came up with the bulb syringe and the hose, the valves have two jobs: to let blood through in one direction and to keep it from leaking back. So in this vein, you can have two types of problems with a valve. Your valve can become leaky, or it can become narrowed and not allow the blood through like it should. Some valves have problems in both veins. They can have leak and narrowing. So why is it important if you have valve disease to get treatment? So this picture, like I said, we're going to focus mostly on the pulmonary valve. And in this picture on the left, you have a picture of a pulmonary valve that's working well. Once the blood has been pumped into this artery, it's not leaking back at all. Whereas in this picture, you can see that drop of blood leaking back, and that is a leaky pulmonary valve. So valves, as we started to talk about, can have insufficiency or leak. And when you have pulmonary insufficiency, what can happen? Well, it may or may not cause symptoms, and that makes it a little tricky. Some of the other valves, even with a little bit of dysfunction, you get some symptoms, but the pulmonary valve, you can live a while with a dysfunctional pulmonary valve. And so it's important to know, to have echoes, pictures of your heart to know how well that valve is working. Because it may or may not cause symptoms, but what it will definitely do if the valve is leaking is cause your heart to enlarge, the right side of your heart specifically. As that blood leaks back, it's extra blood in the right side of the heart when that side of the heart is relaxing. And over time, that will cause that ventricle to dilate and get enlarged. Dilation can ultimately lead to heart failure, and that's what we're trying to avoid. Also, when the ventricle becomes dilated, you can develop dangerous heart rhythms where your heart beats too slow or too fast, and that can be very dangerous. And dilation of the heart, of the ventricle, is reversible up to a point, but there is a point at which you cannot completely reverse the enlargement of the heart, which is why it's important to get the valve treated and fixed as soon as possible. Now, the other problem that can develop with valves is stenosis or narrowing. When you have pulmonary valve stenosis, that makes the job of the right side of your heart harder than it should be. So fortunately, our pump of our heart is very adaptable. And when you have narrowing of a valve and the job of the right side of the heart becomes more difficult, it rises to the challenge for a while. This leads to thickening of the muscle of the right ventricle, just like if you went to the gym on a regular basis and lifted weights, you would get thickening of these muscles. Well, your heart muscle can thicken as well if it's given a challenge. This kind of thickening, though, is not healthy for it, and over time, that kind of thickening will lead to heart failure if the valve is not treated. Again, dangerous rhythms can occur with thickening of the heart muscle. And if you treat the narrowing of the valve, the heart muscle typically goes back to its normal size. So how do you know when to seek treatment? Like I said, some of these types of valve disease are not likely to cause symptoms until they're quite advanced. And that's why it is so important to stay in care and go to your regular checkups so that we can catch things before they become problems. So sometimes it's really obvious when you need treatment. Like if your plumbing is leaky, it may be really obvious if you walk down the stairs of your basement one day and find 2 feet of water. That's obvious. Then you know you need to seek treatment. But sometimes it's more subtle and you need to move that couch out of the corner to figure out why your living room is smelling so stinky, because you have a leak behind the wall that's causing this kind of molding. I think of coming in for a regular checkup and getting your heart ultrasound and getting your EKG kind of as pulling that couch out from the wall and peeking and saying, is everything really all right? And making sure that it's okay. Another way to know when you need to seek treatment is to ask. You can call your doctor or your nurse in your practice and give them symptoms. If your car is making a weird noise, you used to be able to call these guys, Click and Clack from the NPR show Car Talk, but you can't call them anymore. But anyway, you could call your doctor and say, this is what I'm feeling. This is, do you think this is a problem? And if they do, they'll have you come in and check it out. More and more these days, also with coronavirus, we are becoming more and more facile with telehealth, and most doctors now will offer a visit over a video chat or something like this, where you can explain your symptoms, show them something, and a lot can we can get a lot done over telehealth. And so if you're worried about coming into the hospital during COVID, that's a good option. So regular follow-up is important. You'll hear me say this over and over and over again. This can detect problems before symptoms arise. Sometimes it's okay to wait for symptoms, but when that symptom might be a dangerous, life-threatening arrhythmia, then you don't want to wait until the symptom arises. You want to get regular follow-up. Find a doctor that you trust. So building this relationship will really, really help you take care of yourself, because it's your heart and your body, and you need to be educated about it, and you need to feel comfortable asking your doctor questions. And if you don't feel comfortable asking your doctor questions, then that's not the right doctor for you. So I would encourage you to always ask questions about your heart or your child's heart. And if you don't feel comfortable, there are always other doctors that you could visit. And then listen to your body. This one's challenging because there are a lot of things that strain our bodies every day, but don't ignore your symptoms. And one thing that I tell my patients to do is to have an exercise marker. And what do I mean by that? You know, a lot of people say, I don't have time to exercise, or you know, they groan when you say exercise. And I groan too, because I have a hard time finding the time I want to exercise. But all you need is a flight of stairs or something that is easy for you to access every day, and walk up that flight of stairs or walk up that hill or walk around that block and think, okay, how do I feel? And then you'll have a better idea of if your heart is starting to limit your ability to do that exercise, even a short 30-second exercise, and you'll have a better idea of if things are becoming problematic. So what are some symptoms of valve disease? How do I know if my valve disease is becoming problematic for me in a symptomatic way? Well, you can have shortness of breath. More exercise can become more of a challenge. Some people in the late phases get swelling of the legs or the abdomen. A lot of people complain of fatigue, palpitations, which are when the heart does an extra beat or you feel a fluttering in your heart. You can have weight gain, you can have weight loss. You can end up needing to sleep propped up on pillows because a leaky valve is causing fluid to build up in your lungs. And you may be thinking, boy, I have a lot of these symptoms and I don't think I have valve disease, or I thought only my child had valve disease. Well, it's tricky because many of these symptoms are not specific to heart disease. Some of them are really common when we don't get enough sleep or enough exercise. So it can be hard to know if your valve disease is progressing or if you've just gotten out of shape. And sometimes the only way to know is to go to your cardiologist and get an exam or an echocardiogram to look at the valves directly. So I take care of many young mothers who they themselves have congenital heart disease. And it's a frequent challenge to figure out if they are tired from their valve disease or from something else, like their children or their life. So I love this cartoon. The doctor saying, I'm afraid that you have something, what's known as children. I have those and they make me fatigued sometimes, but I love them. So how can valve disease be treated? Well, this is a really, really broad topic. And on this slide, I'm just going to show several drawings of different things and several pictures of things of how valve disease can be treated. The most tried and true way is just replacing the valve. And originally it was just surgeons who could replace the valve. They would remove the old damaged valve, as shown in this picture here, and place a new valve, which could either be mechanical, which means made up of all artificial material like metal, or it can be a tissue valve, which means it's made of some biological components. Surgeons can also sometimes repair valves. This is the best because honestly, if you can keep your own valve and it's working well enough, it will last longer than any artificial valve that we currently have. One thing that's amazing, you know, the valves in your car and the valves in your plumbing, they never last forever. But if you have the fortune to be born with healthy valves, they will last your whole life. But if you're on this webinar, somebody, you or someone you love was born with a valve that doesn't work quite right. And so all these ways to repair valves and replace valves are very important. This next picture is a picture of a mitral ring, or an annular ring, and this is an example of when the valve tissue is okay, but the valve is stretched out and just can't do its job because it's so stretched out. So the surgeons will go in there and kind of take a stretched out valve and tighten it up and sew this ring around it to bring the outside of the valve together, and that allows the valve to work well again. So those are all kind of the surgical options, and I am not a surgeon, so we're going to spend more time talking about the other options. This is a picture of something that honestly I don't do. This is more our colleagues who take care of older adults, but this is something called a mitral clip, and this is an amazing thing because it is a non-invasive way, non-invasive meaning we don't have to open up your chest, but we can do this through catheters, to take your own valve and pull the leaflets of it together to make it function better. But I'm more in the business of transcatheter valve replacements. So for about 15 years in the United States, we've been able to replace the valve of many people in just with catheters without having to do open heart surgery. So the technology we have right now is that of balloon expandable valves. So these are two balloon expandable valves, and we'll talk more about what that means. And then after that, we'll talk about what's on the horizon, which is, and when I say horizon, it's not the distant horizon. We're hoping like within a matter of weeks horizon, we will have access to this new technology, which is not a balloon expandable valve, but a self-expanding valve. And we'll talk about that too. There are so many different ways to treat heart disease though, and no one person is an expert in all of those ways. Your cardiologist is pretty good at knowing all of those possibilities, but to really get into the nitty-gritty of all the possibilities of valve repair and replacement, you really need to have access to the people who do those things. One thing that we are doing at our center that's new is having a specific valve clinic where a patient can come in and actually meet with a surgeon and a cath doctor and their cardiologist, so that they can hear from the person who would be doing the procedure what the different options are. And we developed that for certain patients where the path forward is not totally clear. It's not totally clear if it would be better to try to repair the valve or to replace the valve, and whether it would be better to have a mechanical valve or a biological valve. And this kind of clinic can be really helpful. That's not available everywhere, but even where it's not, all you have to do is ask your cardiologist, hey, would it be possible for me to talk to the cath doctor about this? And they will certainly allow you to do that. They'll make that possible. So, but right now, it's just you guys and the interventionalist, the cath doctor. So I apologize, I don't have access to any surgeons right now, but we will talk a lot about transcatheter things. So transcatheter valve replacement is a really exciting thing that's happened in the last couple of decades. So the very first time a valve was replaced in a human via catheter was in the year 2000. And then the Mended valve became the first transcatheter valve approved by the FDA, and it was designed specifically for placement in the pulmonary position. And this is really awesome because there's a lot of money in device development for really common forms of heart disease, like older adults with calcium on their valves and their valves becoming narrowed. Kids with congenital heart disease, as you guys in Mended Little Hearts know, there's not as many resources for those kids, and there are not as many patients, and so there's not as much impetus to develop these technologies, and that makes it really special that the Mended valve was specifically designed for our patients, our kids with congenital heart disease. So this was the first valve available in the United States. We started putting it in before 2010 as part of trials, but in 2010 it was FDA approved. And ever since then, the technology has just been expanding and exploding, and we've been able to provide this therapy to more and more patients. And we're about to take another big jump in that direction. So how does transcatheter valve replacement work? This is kind of a picture over here of the valve that is squished onto a balloon. And I'm going to show several different slides that give you an idea of this. And you can find great videos online too. They were all too long for this talk, but great videos online that show you how it goes. But you put it in a vein in the leg, or sometimes we put it in a vein in the neck in a smaller child. And the valve, while it's squished onto the balloon, goes up and into the heart. And once it's in position, like this, what we do is we inflate the balloon from outside the patient's body, and that pushes the valve and the stent that the valve is housed in against the walls of this area. And then you take the balloon out and the valve begins working immediately. So this is our most common type of transcatheter valve right now, is this balloon expandable valve. And let me show you some more pictures. Here's one, a closer up picture of the Melody valve specifically squished down onto the balloon. And here we're inflating the balloon, and you can see that that stent is getting larger. And once the Melody valve is fully expanded and you look down the barrel, you can see these leaflets. And this is the valve in the closed position. And these balloon expandable valves work great as long as you have what's known as a landing zone. The valve stays in place because the balloon pushes the stent out against the landing zone, and the landing zone in the heart where the pulmonary valve should be, and that radial force is enough to secure the valve there as long as the landing zone is firm enough to kind of push back and provide support. I sometimes describe it to my patients as a landing zone is kind of like a door frame. A kid can only climb a door frame if the door frame's firm and not giving way to the pressure that they're putting on it. So this kid looks happy in her door frame. She's found a landing zone, and she won't fall out unless she releases the pressure she's pushing. She can trust that door frame to hold her in place. So here's an example of where balloon expandable valves are perfect. So this is a picture of a patient with, or a drawing of a patient's heart with tetralogy of Fallot. And if you remember from Dr. Justino's talk, I'll just review briefly. Tetralogy of Fallot is a type of congenital heart disease where the ventricular septum, the wall between the two pumps of the heart, has a big hole in it. And the top part of the ventricular septum is kind of pushed forward in the heart towards the pulmonary valve. This tiny little thing here is the pulmonary valve. So part of tetralogy of Fallot is that the pulmonary valve, and you'll hear me call this whole area of the muscle below the pulmonary valve and the artery above the pulmonary valve, we talk about that as the right ventricular outflow tract, or RVOT. And that valve is small in tetralogy of Fallot. And so blood comes into both of the ventricles, and most of it goes out the aortic valve into the body. And because not enough blood is going to the lungs, some of that blue blood goes to the aorta, and those babies tend to be a little blue. Their oxygen levels are lower than normal. So sometimes tetralogy of Fallot and other types of heart diseases have to be repaired with what we call a conduit. So basically, the right ventricular outflow tract, including the pulmonary valve, is replaced with an artificial conduit. And these can be made out of, they're usually made out of biological materials, but it's depicted in this picture as this sort of ribbed conduit here between the right ventricle and the pulmonary artery. So if you have had surgery and you have one of these conduits in, then you are likely a great candidate for when you need a new pulmonary valve in that area, because those conduit valves do wear out over time. You're a great candidate to have a balloon expandable valve implanted there in the conduit. And one of the questions I get a lot when I'm talking to a patient before doing a transcatheter valve replacement is, well, what happens to the old valve? And one thing that we really cannot do with catheters is to remove a lot of things. And so we don't remove the old valve. It honestly just gets squished out to the side, and the new valve has that stent around it to protect it and allow it to work. So the old valve stays in there. Now, this we can squish old valves out of the way many times, but not forever. Eventually we will run out of space in there. It's a little bit like nesting dolls, those Russian nesting dolls, and each one is a little bit smaller. Now we can push the material out a little bit, but eventually we'll come up on a limit to how many times we can replace a valve this way. So even though it can replace many of the times that people used to have open heart surgery for valve replacement, it doesn't completely take surgery out of the picture, because eventually you would likely need a valve replacement by surgery to take all the old valves out. So here's an example of somebody with one of these conduits, and this conduit had shrunk down quite a bit. You can see that here, you can see actually some of the old leaflets of this artificial valve in here, those little fine white lines here. But you can see that the conduit was meant to be this size, where it is larger up here, but it's shrunk down quite a bit. So not only is this valve shrunk down, giving that patient pulmonary valve stenosis or narrowing, it's also leaking a lot. If it weren't leaking, when I took this picture, putting in this contrast agent up here to light up the pulmonary artery, I wouldn't see the dark contrast leaking back into the heart here, but I do because the valve is leaking. Here is that very same patient after getting a transcatheter pulmonary valve, a balloon expandable pulmonary valve. So you can see that the area where the valve is much larger now than it was before. And you can see that this is the same patient, because you see this sternal wire with that same fracture, and you see that this other sternal wire is where that small part of that valve was. And now that valve is much, much, much larger, and there's no contrast leaking back here into the right ventricle. So this is great news for this patient. And this particular patient was very young when he had his first operation, and he was less than a year old. And we put this valve in when he was about 7 years old, and we hope to be able to put another one in when that valve fails. So why am I talking about valves failing? Well, unfortunately, we don't have a valve, an artificial valve yet that lasts forever. Many of these transcatheter and surgical valves can last for a decade or more, but eventually they wear out over time. So we have to prepare for the possibility, or for the inevitable fact that we need to replace the valve again in the future. So do balloon expandable valves work for everyone? No, they don't. And here's an example of when they may not work. So we talked about some patients with tetralogy of Fallot and other types of congenital heart disease get a conduit as part of their repair, which includes an artificial pulmonary valve. More patients get something called a right ventricular outflow tract reconstruction. So that's a lot of words, but basically, as part of the repair of their tetralogy of Fallot or other diseases, rather than putting in an artificial pulmonary valve, the surgeon will, after closing the VSD, enlarge that area that's too narrow by opening it up and putting a patch on it. And that's what this little stripy thing is here. That's representing a patch that makes that right ventricular outflow tract larger. Now, if you can imagine you had a teeny tiny pulmonary valve that maybe had some leaflets in it that work, and then we're going to cut open that valve and put a patch here on top to make it larger. That is great, and you do not have stenosis or narrowing of the valve anymore, but the valve leaks freely. And you can live many, many years with a leaking pulmonary valve, but eventually that will cause problems. Like we talked about before, the enlargement of the right side of the heart, and ultimately heart failures and problems with your heart rhythm. So what can we offer patients who have had a leaky valve for years from this type of reconstruction? Well, that's a problem that's being worked on even as we speak, and there are many different ways it's been worked on. So I'm gonna that's a particular area of interest of mine, and I'm going to go into that some of the studies that we've done looking at that. So just so it's clear what we're comparing, the still picture to your left here is that conduit that I showed earlier. It's small, and I needed to put in a video for the patient with the reconstructed outflow tract with a patch, just so you could understand and appreciate the difference. So you can see on the right in that video that there is really a much larger outflow tract, and you can see that the contrast is kind of sloshing back and forth in there, and that if I were to stop this video at a certain point, oh, doesn't want to let me do that. Let's see. So here, it doesn't look too huge, but then as the heart beats, it expands and contracts. So that is floppy tissue. That is not a good landing zone door frame that we saw that little girl climbing. This is kind of like those things you see advertising at tire places where the arms are flopping. You know what I mean? But it's harder to find a landing zone in that sort of area. Sometimes though we can. So we start out trying to measure in patients like this before the new technology came along, and we'll talk about that soon. But when we only had balloon expandable valves, we would measure the area with a CT or MRI before doing a cath procedure and try to tell whether or not a patient was going to have a good landing zone for a balloon expandable valve. And the CT and the MRI could give us some information about the width of the area, but what it didn't tell us everything we needed to know, because it couldn't tell us how stretchy the area was. And sometimes the only way to identify if there's a landing zone for a valve is to actually stretch the area and see what happens. But the only way we can do that is in the cardiac cath lab with what we call a sizing balloon. So you can see in these pictures, the picture to the left, when I inflated that sizing balloon, I saw a nice waist in the balloon. There's something circumferential pinching that balloon. Here where we took this measurement of 14 millimeters, this was reassuring and told me there was a place where I could land a transcatheter valve. This picture so here's that picture where the patient got the transcatheter valve. The picture to the far right shows us inflating a balloon that just keeps inflating, and we never see an indentation on the balloon. And when we only had balloon expandable valves, we would often bring patients to the cath lab hoping that we could find a landing zone for this balloon expandable valve, but we couldn't always. So we wanted to know, to try to better predict who would be a good candidate for this balloon expandable valve. And so our center teamed up with 10 other centers, and we looked back at all the patients who didn't have a conduit but had a reconstructive or a natural right ventricular outflow tract, all those patients who came trying to get a Melody valve. And when we looked at this study, we all knew that a lot of patients weren't getting the valve, but I was surprised at how high that number was. Nearly half of the patients that we had brought to the cath lab during this time frame, and this was 2010 to 2014, but nearly half of them ended up not being able to get the valve. And for the most part, that was because they didn't have a good landing zone. So now, nationwide, our success with just the balloon expandable valves has gotten better. We've gotten better at choosing good candidates. And we've also, new and larger valves have become available, balloon expandable valves that have expanded the number of patients we can offer this to. But balloon expandable valves still do not work for all patients. So what do? Do we try to climb the door frame in the old way and just fall flat on our faces? No, we try to get creative about ways to get a valve in there. So this kid's being pretty creative and impressive. There, you can't really see it, but there's a piece of candy in that vent up there that he's going for. Thought that was kind of funny. So this is one of our most exciting new innovations that is coming down the pipe. It is not approved yet, but we're hoping it will be soon. And this is a self-expanding valve. This particular valve is called the Harmony valve, and it is a really cool design. The balloon expandable valves, I have total control of what shape those take. I can bend it, I can change the shape, and it will keep whatever shape I make with it. These self-expanding valves, you can crumple this thing down. It's very malleable, but as soon as you let it go, it pops back into this shape. And so you can see that it's an hourglass shape. And the idea of it is, in that very large type of outflow tract that I showed you earlier, this can secure itself at either end, and the valve is contained within this narrower part of the outflow tract. And so essentially this device does two different things. It narrows the enlarged right ventricular outflow tract and also puts a new working valve in there. I'm going to show you another picture that shows the valve itself. But I also want you to notice, before I go on, these tiny little loops on the bottom of this valve. This is, I mean, I hats off to the engineers who designed these things, because they are very creative. And that's one of my favorite parts about this valve, is the way that it's held onto the delivery system and released. And I'll show you that in this next set of videos. So this is a patient of ours who had a Harmony valve replacement as part of the trial. And here you can see the other picture I showed you of the enlarged right ventricular outflow tract was a side view. And this is kind of a front view. And you can see again, the contrast is sloshing back and forth in this patient's heart. The pulmonary valve should be right here in the middle of this video, but there's really not much that you would call a pulmonary valve. You can just see the hint of a narrowing where it was. And that's because this patient has had a transannular patch, and so they're only just small leaflets that can't touch each other and hold the blood from leaking back in the heart. So these videos are a little hard to see because the valve is so light, but if you look closely, you'll see this is the Harmony valve being deployed in this patient. So right here, just the top part of it has been released, and now we're uncovering the rest. And you see that top part of the hourglass is open in there, but the bottom part still hasn't been released. And if you look closely, it's almost like a little screw here on the bottom. And in this third video, I'm going to stop these other two because it's getting to be a little much. But if you see here, we're untwisting that little screw, and you'll see one by one the bottom tines of that being released, and now it's completely released in there. And this particular patient had beautiful pictures by ultrasound, so I'm going to switch modes to ultrasound here. And here you can see kind of the hourglass shape here and the leaflets of the valve opening and closing. And this is just beautiful. Here with color that shows the blood flowing and not leaking back. And this patient immediately felt much better. Had been really fatigued and had a hard time even walking down the block, and she had immediate improvement. Some other new innovations that are I won't say coming down the pipe, is sort of the collective creativity of the engineers plus the physicians that do this kind of work, but it's replacing other valves. So using valves that were designed for one thing and using them in other valve positions. This is not such a thing. This valve is actually designed for this, but at our center, we have started replacing some aortic valves with catheters. And here's an example of a patient. Here I'm putting the contrast in above this patient's aortic valve here. And you can see that the valve is opening and closing, yet a lot of the contrast is leaking into the ventricle here. And these small arteries are coronary arteries here that supply blood to the heart. And then this patient got a different kind of balloon expandable valve, and you can see here that there's no contrast leaking back into the ventricle anymore, and that the blood is going to the coronary arteries well. And this technology is available pretty regularly now to older patients, but we're trying to expand it to younger patients too. And this particular patient was one of my patients who runs cross country and went from being kind of middle of the B team pack to leading the A team pack after this, and that was very satisfying. Here's another example. This, if actually I'm going to click back, you can see that this patient had never had heart surgery. You don't see any sternal wires, and this patient's first valve work was transcatheter valve work. This patient, on the other hand, is no stranger to the operating room and the cath lab, but she had an artificial tricuspid valve right here. And again, you see the contrast is leaking back behind that valve. And here we've put a Melody valve into that tricuspid valve, that pre-existing tricuspid valve, and now the valve is functioning well. So, okay, but you guys out there are parents and patients and people who want to know what it's like when you have this procedure done. And these are quotes that my own patients have said following the valve procedure. And I meant to add a fifth one in here, so I'm going to make sure I say it. But first of all, I had one patient say, my legs have been so swollen, and this morning, the day after the procedure, it's the first time I've seen my ankle bones in years. So you really can have that kind of immediate improvement in your physical condition from a valve replacement when you have bad valve disease. Another patient of mine said his mile time was a full minute faster than last month, and that was even with taking a week off training. So he said a week off training because when he got his transcatheter valve, he was in the hospital overnight one night, and then we asked him to take it easy and only walk for the next couple of days and only do light jogging for a few days after that, and that he could be back to full activity after a week. So you really can get back to life very quickly after a transcatheter procedure. This patient said he could finally walk up the stairs without having to take a rest at work. He felt embarrassed that his colleagues would decide to take the stairs and he would have to take a break on the landing, and he felt much better. And then one of my favorites, and then I'm going to say the fifth favorite, but I had a patient recently that told me his new valve felt like a Lamborghini. And not being much of a car person, I don't know much, but I know that Lamborghinis are pretty smooth. I also had a parent recently bring her child back in to clinic and say, can you please take it out? She has way too much energy now. So sometimes parents get used to having a child with a mild or moderate degree of heart failure, and then you replace a valve and they have much more energy after that. So after the valve, what can you expect? So post-treatment, you are often going to be asked to take some medication, often aspirin, and then we'll get into other medications. But first of all, ask questions. When you follow up, like, what do I need to do to keep this valve working well? What can I do? What can I expect? And so things that I tell my patients to keep their valve working well, the first one is to take their prescribed medication. And we often will prescribe aspirin, and that is especially important right after the valve goes in, as the rough edges are being endothelialized, and that's when the lining of the vessel kind of grows around the sides of the new stent that the valve is in. And many people, including myself, recommend taking lifelong aspirin because there are some small indicators that aspirin prevents certain problems with valves. And so I tell my patients if they can tolerate taking a baby aspirin every day, they don't have bad nosebleeds or something, that I recommend it. Come in for regular monitoring. We have protocols to monitor valves that are based on things from the studies from which the valves were first implemented, and that helps us pick up on problems early if there are going to be problems. And fortunately, that regular monitoring is often just just, a feel-good session about how well the valve is working. But every now and then there is one that doesn't work as long as we hope, and we want to be able to pick that up early. Brush and floss your teeth. I had one patient the other day say, why are cardiologists obsessed with dentists? And I laughed and realized that I hadn't done a good job of explaining what that connection was. But our mouths have lots of bacteria in them. And every time we go to the dentist and they scrape up, clean our teeth with the little scraper tools, and you get a little bit of gum bleeding, and they ask you if you've been flossing, we get bacteria in our bloodstream whenever that happens. Now, if you don't have an artificial valve, if you have all your own valves, then that's fine, and your immune system will clear it. But if you have an artificial valve or other kind of heart hardware, you may have bacteria settle in that area and cause infection of the heart valve. And so that is why we're obsessed with dentists and brushing your teeth. On that same note, we're going to ask you to take antibiotics before you go to the dentist if you have an artificial valve. And the idea there is that that antibiotic will not allow that bacteria to live in your bloodstream long enough to settle on your valve. And then exercise. Now, in full disclosure, I don't know that exercise extends the life of an artificial valve, but it will extend the life of your heart. And so it's all that much more important that patients with congenital heart disease get exercise, like we all should. And finally, stay in care. So with regular care, small problems can be picked up and identified and corrected before they become bigger problems. That is all I have for today. So please let me know if you have any questions.
Hey, Dr. Martin, this is Mandy. Great presentation. That was excellent. Thank you. We have one question so far in the chat box from Stephanie, and she asks, my child with TOF, tetralogy of Fallot, has a 29 millimeter sapien valve. Is there a limit of 2 valves that can intercase with each other using the cath lab before the sapien valves need to be removed from the heart?
That is a great question. So that is the largest balloon expandable valve on the market that we use in congenital heart disease. And the short answer to your question is, I don't know yet. We have placed one more balloon expandable valve inside an existing one. And I have no reason to think we couldn't put a third or a fourth. But I do think eventually we're going to run out of room. And it's hard to know when that would be for a particular patient. But I do think it's reasonable to think that the next valve replacement could be within that 29 millimeter valve, and probably the one after that as well. And what I do tell patients, and I don't think this is overly optimistic, is that my hope is that by the time we run out of room, there will be something better. Some kind of artificial valve or even genetically grown valve that will not wear out over time. And I'm not in that field, but I know people that are, and it's not going to happen in the next 5 years, but it may happen in the next 25 years.
Thank you. Greg asks, what factors determine if a young person is a candidate for a transcatheter aortic valve replacement? Is the TAVR an option when the Ross procedure is being considered?
Oh, great question. So you could ask 10 different cardiologists that question and get 10 different answers. Our group in particular has been pretty excited about TAVR or transcatheter aortic valve replacement when there aren't other great options, like when the Ross is thought not to be a great option. And the Ross procedure is fraught with issues. When it goes well, it is great. I think, personally, if my child needed an aortic valve replacement and I had a surgeon that somehow could guarantee me a good Ross procedure, then that's a great option. It is trading aortic valve disease for pulmonary valve disease, and many people do not like the Ross because they say now the patient has 2 kinds of valve disease, because often the valve that's put in the aortic position, the old pulmonary valve, doesn't last forever either. But I still think it's a really great option when it works well. But a lot of the patients that we have done TAVR in were considered for Ross, and we laid out the options for the families, and they chose the TAVR. And the TAVR is not going to last forever, but we think it's a good option, especially for teenagers and young adults who are living, like still doing active sports, maybe playing soccer, maybe want to have children, things that are hard to do when you're taking Coumadin or another powerful anticoagulant. And so they don't want a mechanical valve, which is another option that would last a lot longer, but you have to use anticoagulation. So this is a long answer to your question, but often if the Ross is being considered, the TAVR could also be an option. But it is rare, and we're kind of on the cutting edge of that, offering that to younger patients. But I do think it's going to enter the mix more and more as an option.
Thank you. Christy just wants to thank you for all the great information. And then we've got a few more questions. Chip asks, can you comment about the option of a valve-in-valve in an adult patient with a 21 millimeter tissue valve in the aortic position?
Great question. So it depends on the type of tissue valve. So 21 millimeters, most 21 millimeter tissue valves that have been surgically placed, the true inner diameter of the valve is a little smaller, probably around 19 millimeters. The smallest aortic balloon expandable valve we have is 20 millimeters. And even the company says, you should really only use the 20 millimeter valve for a very small adult. Some tissue valves that are surgically implanted have a ring, a metal ring or a plastic ring that you can actually fracture intentionally with a balloon. So let's say the inner diameter of that valve was 19 millimeters, but we wanted to put in a 20 millimeter valve. We could fracture that ring and put it in. But it may be that a 21 millimeter valve limits your options for getting a big enough transcatheter valve. And so that valve may need to be replaced surgically, but it would depend on the type of valve. Thank you.
How long is the normal life of TAVR, and what's the norm for the valve?
Right. So we're still getting data on that. When I place a transcatheter valve in either position, kind of from compiling all the studies that we have, I tell people that the average life is going to be 7 to 10 years. Now we have Melody valves that have been in longer than 10 years. The other types of valves we haven't been putting in as long, so we don't have data past 10 years. But I think what I tell people is 7 to 10 years based on the general data that we have for all the valves.
Thank you. And Stephanie asks a second question. Have mitral valve clips been able to be used in children with tetralogy of Fallot who have severe tricuspid valve regurgitation? How does this affect the pulmonary valve?
Great question. So patients with severe tricuspid regurgitation, if they also have problems with the pulmonary valve, our first step is to repair or replace the pulmonary valve. Well, replace, I should say, with a catheter valve, because often that actually helps the tricuspid valve. But if your patient, or if this patient has just tricuspid leak, we have had, I can think of 2 instances in when we've used a mitral clip with the help of our colleagues who are in adult cardiology to improve tricuspid insufficiency. So it has been done, but it's rare. The company that does the mitral clip, and actually more companies, I believe, are working on a tricuspid product that's in study phases. And so it is a technology that's going to be able to help the tricuspid valve. In a smaller patient, though, I think the delivery system for the mitral clip may be prohibitive for a small patient. I can't think of any children that we've done that in that were younger than teenage. But I do think that technology is rapidly improving, and so it's going to be more likely to be an option in the future.
Thank you. I think that's all the time we have for questions. I'm going to turn it over to Andrea so that she can let us go for the day.
All right.
Great, thank you. I just wanted to thank everyone for joining the webinar today. Hopefully you enjoyed it. Dr. Mary Hunt, Martin, thank you so much for joining us. It was an amazing presentation. The webinar will be on YouTube and it will be posted on our website following the event. It usually takes 24 to 48 hours, but we will send out the link to all of the registrants. So thank you all for joining us today and have a great day.
Thank you all again for inviting me. It was a pleasure.
Thank you so much. That was excellent.
Bye.
Everyone.
Bye.